and Surgery Center Vieira. We are getting ready to perform spine surgery on the lumbar spine or lower back. Our patient travels to us from Texas to Florida, and his story is one that to me is so sad and unfortunate. It represents the worst of medicine. He had a fusion done, which, to be honest, the fusion looks okay at L4-5, L5-S1, but he developed adjacent segment disease, and the herniations have gotten so large that they were pinching the nerves, causing weakness in his legs. I told him to come to Florida immediately to get surgery. He couldn't get any help where he lived in Texas. They refused to treat him. He is obese. He weighs 360 pounds. So 360 pounds. He's a big, big man. And nobody wanted to help him because he's so heavy. But I recognized that his weakness was getting worse. He was desperate. He came to Florida. And just a week ago, he informed me that he couldn't walk anymore. He's basically in a wheelchair now. And he has zero strength in his legs. His nerves are crushed. So he has what we call Cauda equina syndrome. Cauda equina syndrome. And it is an emergency condition. We're going to do our best to fix him. I told him because of his large size, there's a chance I can't do the surgery. He was aware of that. I told him there's a 10% chance I won't be able to do the surgery because he's so big. Because our instruments are designed for smaller people, you know, and there gets to be a point where they're too big and the instruments won't fit. And we have the biggest and best instruments, but he may be more than what we can handle. So he was prepared for that potential eventuality. So we're about to find out whether we can fix this problem or not. All right, let's get started. If you have questions throughout the surgery, feel free to ask them. I'm going to start by numbing up some skin, and we're going to put a needle in to access the disc. Injecting. Now his herniated discs are actually on both sides, left and right, and he's quite literally paralyzed in his legs. His entire family is here with him to support him. They're all from Texas, and his wife is here. I think it's his brother-in-law is here, and they're here to support him and help him. So they're watching right now, and I told them I would do my very best for him, but it may not be good enough. So we'll see. God willing, it is. All right, let's try the other needle first.
Yes, sir.
What do you think? Think we might get it with the smaller needle? It looks a little too small. Well, let's give it a try. Now remember, he's already been fused, not by me, but by another surgeon at L4-5 and L5-S1. So basically, we're going above the fusion. Shot? Yeah. So I need you to move a little bit south, if you could. And you could see on the x-rays, I'm going to have Jordan take another picture. You could see on the x-rays the two discs that we're targeting. Show them, Jordan, just above his fusion, that disc there, and the one above that there. So that's what we're targeting. And you could see his screws and rods from his fusion. It's one of the reasons we don't do fusions, folks, is something called adjacent segment disease. Essentially, the disc above the fusions can actually go bad and cause problems. And that's what's happening in this patient. Yeah. And if I have to make two separate incisions, I will. The goal here is not to do few incisions, it's to fix the poor man and get his nerves unpinched. All right, if you have questions during the surgery, please let me know. I do want you to know that most people we operate on, we're doing surgery for their Sean? Well, I have a feeling I'm off, so let's see. Let's just get an AP. Most people we do surgery like this for, it's a herniated disc that is causing back pain. Our patient here has a herniated disc causing back pain, but he also has the same herniated disc crushing the nerves into his legs. And so it's not just causing back pain, it's causing leg pain. And that leg pain has now evolved into weakness, literally complete paralysis of his legs. So I'm going to do my best to go in there and get the pressure off the nerve roots, okay? We're not too far off. We're actually pretty close to where we need to be. Shot. And I should be hitting the facet right there, which I am. And now I got to get around that facet. Shot. So we're actually not too bad. Better than I expected. Shot. God willing, this will go well for the patient. I'm really praying. I actually woke up this morning. I told my wife, I said, "Why'd you wake up so early?" I woke up at 5:30. And I said, "I couldn't sleep." She said, "Why couldn't you sleep?" I said, "I'm thinking about this patient I have today who's basically paralyzed in his legs. And I've got to try to help him." Shot? And I'm worried about him. I'm really worried about whether or not I can help him. Shot? Give me an AP. I actually lose sleep over my patients. And it's fine. I'm not tired or anything, but this patient in particular I worry a lot about. He's in such a bad shape. That looks good, actually. That looks better than I thought we would get. But so we're really at the limit of the needle, the spinal needle we typically use, but we're in a really good position. And I'm really happy with my trajectory. So it's actually better than I thought. I could feel the herniation. And we're going to go inside. Shot. He has a huge herniation. So I'm going to actually make an incision. Now, normally, let's do some num-num. Dr. Berndes, how is the intubation? I want you all to know this patient's actually intubated with the tube down. Why? We decided to do it this way because we're not really doing the surgery for back pain. We're doing it for crushed nerve roots that are causing weakness in his leg. So he's also so big, obese, and I have no problem saying that because it's true, but the size of this patient puts him at great risk for airway complications during surgery, which we really don't want. So as a matter of fact, we decided as a team the safest way to do his surgery is to make him sleep so we could secure his airway and make sure we don't lose his airway. Last thing in the world we want is a patient who already has enough challenges in life now that they don't need to have a problem from the surgery from the airway. So he is asleep and intubated. All right, let's see if I can fit another needle right here. Now his incision is going to be a little bigger than our normal, and that's just because, again, let's see a shot. All right, so the needle's still in a good position. Let's do this. I've got an idea. We're going to do things a little different. I'm going to do the discogram and then the guide wire. I'm going to take this out so that we can actually have more room to put the next needle in. Because you can see the needle is so deep, it's tenting his skin because he's a big guy. So I'm going to do my discogram here. And I'm wondering before I do that if I should put the other needle first. So let's do the other side at L3-4. You ready, Jordan? I think you're okay. So I'm going to enter about the same level because it looks like a really good entry point. And I'm going to come in right around here. And shot. May want to be a little bit higher, it looks like. Shot. And I'm aiming for the same disc. Shot. Okay. Aiming for the same disc and hoping that we can get there. Need to be a little bit more north. Shot. That's too much. Shot. Should be right around the facet, which, there it is. Shot. Perfect. Shot. So I can feel the facet. Shot. I'm starting to go around it, which is what I want to do. How is our patient, doctor? Shot. I wonder if I'm on the transverse process. There we go. Shot. Actually, I just got around it. So, really. Huh? Shot. Dehydrated. Give me an AP. So you're giving him fluids. Once again, the needle is literally at the hilt. So it's maxed out. And I still feel like I could push it down a little bit to get into the right spot, which we will do. So far, it's actually going better than I expected for this patient. Perfect. All right, let's do a lateral. So the first step of the surgery, the Deuk laser disc repair, is done with the spinal needle to gain access to the disc. I mean, so much better, huh, with the intubation? Just able to control him, no movement, completely relaxed, able to ventilate him. Huh? Yeah, you wish every case was like this, right? But, yeah. All right. Any questions from our audience?
Yes, we have a question from Sunil Patel on Facebook.
All right, Sunil, hit me with your best shot. Sorry, Luis, I didn't realize you have it over there.
They asked, hello, Dr. Deuk.
Just hold it, a little pressure. Hello, Sunil.
How many % chances do you think this patient has to get back on his feet?
Sunil, that's a great question. Sean, how come the dye is not so dark? Interesting. It's just shot? Yeah. All right, well, we got the blue dye in there, which is what I wanted. Oh, look. It's coming out the other needle. Can you guys see this here? The
yes,
dye right there?
Yep.
So the dye, I actually injected it in this needle. It went through the disc and out the other needle. We're definitely in the disc, so that's a good sign. So Sunil, you're asking me what's the chance this patient will get back on their feet? And you know, the problem is that they're already paralyzed. Literally, on a motor exam, a neurological exam, the nerves here are so crushed that he cannot even move his legs. He has to pick his legs up, and he's been living in a wheelchair, you know, and I'm concerned that the strength won't come back. And I told the family that. I told them, but they understand that his only chance of getting his strength back. Can you bring the collimator in a little bit off the back? It's showing my fingers there. The only chance, or Luis's fingers. No, you're fine. The only chance of getting back to as close to normal as possible is with surgery. So surgery is an absolute must. And the type of surgery he should have, really, there's different options. But you can see the guide wires in the L3-4 disc. That's what I want. So I'm going to leave the guide wire, take the needle out. We're done with that needle. I'm going to use the same needle, I guess, to do the next level. Okay? Why not? I would say the chance that he goes back to being able to walk is 50-50 with the surgery being done perfectly. 50-50 with the surgery being done perfectly. That would be my estimation, okay? Without surgery, he's never going to walk again. He'll be paralyzed the rest of his life. So he has to have surgery to get that 50-50 of being able to walk again. I think there's a chance he's going to have to walk with a walker the rest of his life. There's a very distinct chance of that, okay? But that is the reality of his condition and his situation. I think that the opportunity to fix him and prevent this is past. It should have been done in Texas a long time ago by his doctors, but they ignored him. They didn't want to deal with him. Why? Why do doctors blow away or blow off patients like this? Well, it's simple. It's nothing to do with his name or his ethnicity. It has everything to do with the fact that he's obese and that he's had back surgery before. And doctors don't want to do back surgery on a patient who's had back surgery. Why? Because they're not confident in their skills and their ability to help those people. Okay? I am extremely confident. Why? Because I've helped hundreds and hundreds of people like him. Not as bad as him, but I've fixed these people all the time. And I'm very confident in my skills. I know the risks. I know the chance of a complication is very low with this procedure. All right, AP. So I recognize this person needs help desperately to have a normal life, and that I have the God-given ability to help him. I have the team, I have the anesthesiologist, I have the facility, I have the experience and knowledge, and so I am, wow, way off. I am willing to use everything we have to try to help him. All right. So we're not quite where we need to be with that other needle. By the way, for those of you watching, you can see that we use X-ray machine to take pictures while we're doing the surgery, and we use the X-ray for two reasons. One is called localization. I need a shot. Localization means finding the target, identifying the target on the X-ray. And then the other is navigation, which means getting to the target. Getting to the target. So we need to localize and we need to navigate. Now, because he has scoliosis, I feel something, Sean. I think it's the facet. Because he has AP, he has scoliosis, his spine is also twisting away from the left side, going towards the right side. So it's actually moving away from me, which makes the surgery even harder to do, but not impossible. There we go, much better. Okay, so we're close. What other questions do you all have?
No current questions, but we do have a comment from Tom on YouTube, and he says, "Best of luck, doctor."
Thank you, Tom. I appreciate it. Please pray for this patient, if you would. He needs all the help he can get. I'm really worried about him. All right, that said, let's have the audience see, why do people get back pain from a herniated disc? Let's run our video so they can see that. All right, meanwhile, I'm going to keep trying to navigate this needle tip on the left side to the L2-3 disc. Okay, we're very close. Shot? Very close. We need just a little bit more.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We are still trying to navigate this needle to the to the L2-3 disc. All right, I think we're actually, let's just leave it where it is. The X-ray. I just need to find a way to get there. Shot. Shot. It's too low. Shot. That's really good if we're at the disc. AP? So we're talking about navigation using the X-ray machine to see where the needle is, which we're trying to navigate the needle into the disc and really into the herniation is what we're doing. And I'm using the X-ray machine to do that. All right, so we're still a little bit lateral, and I can't remember what the lateral view looked like. So we're too far lateral on the AP. We're definitely hitting bone, and I'm thinking maybe I'll do a second incision higher up. All right, so we're right there, but we're right at the back of the vertebral body. I think I need to be a little bit more medial. So I'm going to try to redirect a little more medial. Shot. And I'm hitting bone. Shot. I feel like shot. I'm right at the back of the disc. Give me an AP. So again, we're using AP and lateral views to navigate to the L2-3 disc on the left side through a transforaminal approach. This is pretty standard for this type of surgery. Once again, if you look at the needle, it's like I'm at the back of the disc, but a little bit lateral. I want to be a little bit more medial. I think I see what's happening. We're off on the orbit. That's what we're off on. We're about a degree off on orbit and about a degree off on WAG at L2. It's actually not bad. We're not bad. We're actually in pretty good position. There we go. See? That's better. Thank you. Shot. I feel the herniation now. Let's get one more AP, see where we are, verify. So if you notice, I use a lot of X-ray, back and forth, front, back, and side to side. I go back and forth between the views. And some surgeons like to use oblique views as well, so an intermediary view. That's perfect. We're in the perfect spot. So I'm going to enter the disc. What's wrong? Nice. You guys did a great job. Put a Foley in. I love it. Smart. Why not? All right. So that should be going in. And that's in. Shot. Yeah, no. Fluid balance. You did the right thing. I love it. All right. Well, we're going to put our guide. Do you have another guide wire? We only need these two.
We don't plan to use the long ones then? The long needle?
I don't think so. Why, do you want to?
No. What I'm saying is if we need the long one, I need two guide wires, remember?
Right.
That's what I'm saying. But
No. We're not going to need the long one. We're actually where we need to be.
Thank you.
Shot? All right. Let's take this
I have
out.
two dilators if you want to put two dilators.
Shot? Shot? I think we're okay actually. Shot? That's perfect. So we've got our guide wires now. We've removed the needle. So we use this special needle to navigate to the disc, and specifically the back of the disc where the tear and herniation are. Then we put our guide wire through the needle, and the guide wires are skinnier, and there's nothing on the guide wire in this area that would prevent me from putting the next needle in, which I just did. Okay? We're going to go to the right side because he's a bilateral L2-3, L3-4. His nerves are being crushed severely at both levels, and I need to gain access to the 2 discs right here. So we're making a bigger than normal incision. It's not that much bigger, but it's still bigger than normal. And we're going to go through the incision and place this next needle. And this will be the last one. And if we get this one, we're golden. We are going to struggle a little bit with the top of the endoscope because it's a little bit longer than the needle. Shot. But so far, we're doing okay. We may need that long guide wire, that long needle. I don't know yet. Shot. We don't seem to be making great progress here. Just stand by. Yeah. Shot. Too high. Actually, I think we might get it. Shot. Oh, I feel the bone. Good. Shot. Close. I may be on the transverse process. Let's do an AP. Oh, wait. Go ahead. Sorry, I forgot the guide wire was there. Any other questions? Are we back?
Yeah, we've been back. We do have a question. No current questions, but we do have a comment from Bambi on YouTube.
Yep.
And Bambi said, it's by no mistake he is under your care today. He will walk again in Jesus' name. God bless you, doctor.
Bambi, thank you so much for your prayers. I'm praying as well. I've been praying for him ever since I heard about his condition worsening too. And I know our whole team is doing our very best for him. Okay, I just got to get this one last needle in, and I want to do it just right. So let's see if we can make this happen. All right, let's see what we got. Shot. Okay, shot. Too high. Shot. Much better. Feeling better. Feels good. Shot. Still a little higher than I want it to be. Shot. That's looking better. Feel the bone. Shot. I've lost it now with the guide wire there. Shot. It's kind of hard to see the tip of the needle, huh? But it is lined up properly. There it is. It feels good. Shot. I think we're there. Shot. All right. I feel like I'm on the disc, but I have to verify that. You can't just rely on your feeling. Let's get another AP X-ray. So we're very, very close to where we need to be. As soon as I get this last needle in, we're going to be able to, yeah, it's perfect. There it is. Praise God. We did it. All right. At this point, we are where we need to be. The guide wire down below, I could even bring back just a little bit. Shot. Oh, go ahead and do a shot. Yep. All right. We're ready to enter the disc at L2-3. And I can feel the herniation. It is huge. All right. We're in the disc. We've done it. So the hardest part of the surgery we've been able to achieve the success. And I'm going to do a discogram. Remember, we're not doing an evocative discogram. We're doing a chromodiscogram for the purpose of being able to visualize the herniations better. Okay, great. Great job. All right. Do we have another guide wire by any chance? I think it might be a good idea to place the guide wire. As a matter of fact, we are going to need 2 more guide wires. You're right. Yep, we're going to place this one. And then we're going to have one more to start the actual surgery. Shot? All right, so we've got guide wires in place, which are less bulky, by the way, than a needle. Because remember, the needle has that top of the needle, this area here, which kind of is competing for space where we need there to be enough space. just want to make sure everything I do is proper, because we are doing things a little bit different than normal. All right, now we've got our path of safety to the discs. We're going to follow these paths of safety, and we're going to now start the actual surgery that is going to remove the herniations that are crushing his nerves, that is taking away his ability to walk. And let's get started. We're going to start with 3-4, right? Let's start with 3-4. So we're going to run the dilator down right over the guide wire. Shot. Remember, we're coming from the side, so I'm actually shot. I'm coming as far lateral as I can safely. I don't need an AP. So I can try to get the herniations as much as possible that are crushing the nerves. For those of you interested in endoscopic spine surgery, you want to go as lateral as you can without compromising the abdominal cavity, and you want to remain retroperitoneal, and you want to be able to get, by going more lateral, you get more anterior in the spinal canal. I'm sorry, you get more posterior. I meant to say posterior. Let me see. All right, pretty good. We're getting there. Shot. Yeah, take the guide wire out. He looks a little bit like a porcupine, right? Shot. We're inside the disc. So far, the hardest part of the surgery, which is the anesthesia, has been going very well. Now, the second hardest part of the surgery, which is the surgery, has been going really, really in his favor. I think we're going to be able to get this done. And God willing, he'll walk again. Because he's paralyzed right now. Completely paralyzed. Shot. Uh-huh. Shot. Oh, it's going to take it all the way to the max. I think that's good. That's good. Mm-hmm. And let's get a shot. Perfect. So you can see our tube that we're doing the entire endoscopic surgery in is inside the back of the disc. Now we need the fluid adapter on. Yeah, we're going to take the fluoro out. We're done with it. Look at all the blood we've lost, folks. If this patient's surgery was done at the hospital and any other type of surgery, there would be a blood fest. He would be bleeding everywhere because he's a big guy. He got a lot of vasculature. But with endoscopic surgery, there's no bleeding. It's a few drops. Why doesn't this surgery have more popularity among spine surgeons? The answer is because the companies that manufacture the screws, rods, cages that go into people's spines, they don't want this surgery popularized. We don't use any metal, and we're not doing a fusion. You guys could see the screws and rods from his prior fusion. That was done in Texas. Okay? That surgery caused him to need more surgery. And that's what I'm doing today, is the more surgery. Folks, stay away from fusions. They're unnecessary now. The surgery you want is the Deuk laser disc repair. You don't need to have a fusion done afterwards. Okay, let's run a video. There's his herniation, showing the Deuk laser disc repair and how it works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. So I'm going to talk to you a little bit about just how corrupt this spinal fusion and artificial disc businesses are. Are you all ready for this?
I believe we're ready.
Okay. This patient right here that we're operating on had a spinal fusion done in Texas at L4-5, L5-S1. Go back and look at his x-rays. You'll see the screws and rods. Well, folks, exactly what I've been telling you for years. The surgeon who did his surgery was getting kickbacks for putting the metal in. For putting the metal in. Kickbacks. Okay? And guess where that surgeon is today? He's in jail. I just been informed he's in jail with 14 other people involved in a kickback scheme. Now I'm going to tell you folks something. This is happening all over the United States. Kickbacks to spine surgeons putting metal in people's backs. I have never taken a kickback. I never will. I don't need to. It's unethical. It's wrong. But there are spine surgeons left and right on every corner, every academic center. Okay? You look at the big spine surgeons at the academic centers. They're taking kickbacks. The kickbacks are disguised as royalty agreements or consulting agreements or, you know, some type of a way to give money to the surgeon in exchange for doing fusions on patients. You guys are the guinea pigs, the victims. You're taking all this metal, spinal cord stimulators, morphine pumps, screws, cages, plates, rods. Jesus. And it's all for kickbacks for the surgeons putting it in, or pain management doctors. Okay, I keep telling you about it. Here's a living proof. This poor patient had spinal fusion done in Texas. His surgeon is in jail. He told me I can't even go back to my surgeon because he's in jail. He's in jail for how long? 75 years. 75 years?
What is it?
Oh,
All of them.
7 years. 75 years for all 14 people involved in the fraud. By the way, there's the guide wire from the other side. And I've already blasted it with a laser. Shiza. So I've got to try not to blast it too much more. All right, you can let go of that.
Okay.
So, y'all hear that? This is living proof of what I tell you all the time. These patients are getting metal put in, fusions, recommended by their spine surgeons because of the kickbacks that these surgeons are getting. Now, it's not that I don't know how to do fusions. I know how to do fusions. I've done thousands. But I never got a kickback for them. I did fusions because they actually work, as long as you do it right. And unfortunately, 95% of spine surgeons, they don't do it right. They don't know how to do the surgery right. They do one surgery, and then they bring the patient back, and they do another one. And they basically make the patient have to keep coming back for more and more surgeries and more fusions. More and more money for the surgeon. Okay? My point is simple. Avoid metal being put in your spine, folks. Go natural. Go with endoscopic surgery. There are no kickbacks with endoscopic surgery. Why? Because we're not putting any metal in your body. It's that simple. We're not putting anything implantable. Okay? It's pure, it's natural, and it works better than any fusion out there or any artificial disc out there. All right, so we were inside the herniation, and I could see there's a lot of it. And I'm trying to break it up into pieces and float it out. This is going to take a while. So if you have questions, this would be a great time to ask me questions. For those of you who joined late, This patient is paralyzed in his legs from his nerves being crushed. These nerves are being crushed by herniated discs above his fusion. He had a fusion done in Texas several years ago, like 3 years ago, and they did a fusion at L4-5, L5-S1. You saw the screws. Those screws were paid for in blood, okay? Bloodshed. The bloodshed of the patients. Paid for in bloodshed. So patients are getting screws put in by surgeons who are getting kickbacks from companies to put screws in because there's so much profit being made on these screws from a business standpoint. And this surgeon is now in jail, okay, serving jail time for basically bribery, getting paid to put screws in. I'm going to tell you something. There's probably out of 6,000 spine surgeons in the United States, around 5,500 of them are getting paid kickbacks of one form or another. Be aware, his situation is not uncommon, okay? If you want to know the truth, just look at a paper, any paper published in a spine journal on spine surgery, and look at the author's financial disclosure. It's required nowadays. All publications have to have a financial disclosure by the authors of who they're getting money from. And it's required. Go look at the publications on artificial discs. Go look at the publications on fusions. And you'll see the authors' names have little symbols next to them. When you go and read about those symbols, it'll tell you what their disclosures were. And they're always getting paid kickbacks in one form or another to put metal in people's backs. And that's why we do our broadcasts, so we can teach people that you don't have to have metal put in you. Don't trust your surgeons so blindly. Find out, do they get kickbacks? Ask them, do you get any kickbacks? Okay, this patient's surgeon was getting kickbacks and he got caught. And now he's in jail. So when this patient needed help for his back, who was there to help him? Well, Deuk Spine Institute was. That's why he's here. But his own surgeon is not, because he's gone. Can't operate too well from federal prison.
The article was crazy. They asked like the officer in the hospital to comment, and he said that we just needed more bodies on the table.
I guess.
Really? Yes, that's what it said.
So I'm getting feedback from the article from the surgeon. If you want to look up the name of the surgeon in the internet, his name is Dr. Sean what? How do you spell the last name? Henry. Henry. Dr. Sean Henry. Dallas, Texas. Is he a neurosurgeon or orthopedic? We don't know if he's a neurosurgeon or orthopedic, but Dr. Sean Henry, Dallas, Texas. Google him and you'll see that was the original surgeon for the patient I'm operating on today. He's in jail because he was accepting bribes for putting metal in patients' backs and necks, okay? And I'm going to tell you something. This doctor is par for the course. I know lots and lots of spine surgeons getting kickbacks. And these people are above the law. And you guys are the victims getting your fusions from them, okay? They're all eventually going to get caught. And they're all eventually probably going to go to jail if our government does its job right. So anyway, things are going well. There's a lot of herniation here. It's taken a long time to work through it. Doesn't surprise me. It's kind of what I expected for this patient, given the severity of the stenosis or narrowing. Any questions?
Yes, we actually have a lot of questions. This first one comes from Dell on YouTube. And their question is, you enter the sheath inside disc and up to anterior border of the vertebral body in lateral view. But my professor used to do it at the junction of disc and the foramen mid particular line. How do you do that?
Well, First of all, welcome to our broadcast. It sounds like you may be a surgeon watching, which is good. And what I will tell you is that your professor who instructed you is using a technique called the outside-in technique, where you start in the foramen and you work your way to the herniation. I learned my technique from Dr. Tony Young. He is probably, in my opinion, the greatest endoscopic spine surgeon for the lumbar spine in the world. But he's now retired. He's done over 10,000 lumbar endoscopic surgeries. He was in Phoenix, Arizona. You may have heard his name. He's published papers. Anyway, Dr. Young taught what's called the inside-out technique, where we start inside the disc and work our way backwards to the foramen. It's a much safer technique. It's the technique that I've used for years. And I would not use personally your technique from your professor. I think it's dangerous and results in a higher complication rate. There's also benefits to doing the inside-out technique that I use, that I was taught by Dr. Young. And there are many other endoscopic surgeons that use this technique, the inside-out technique. Other benefits include the fact that when we place the dilator into the disc, we actually reduce the herniation from the foramen into the disc using the dilator. So it actually helps remove the herniation from the disc. I should say from the foramen, where the nerve root is being compressed. So that's another advantage of the inside-out technique that I use that was taught to me by Dr. Tony Young. But there are two different fields, there are two different groups, disciplines. There's inside-out and outside-in. And it sounds like your professor was a outside-in person. And there's nothing wrong with it, I just wouldn't use it myself because I don't think it's as good. Good question.
This next question comes from John Doe on YouTube. And John Doe asked, "Hey, Dr. Deuk, it's John Doe. My MRI is complete, and my chiropractor and I are going to go over it more in detail. However, after initial viewing, the L5 is collapsed, and the herniation is going off the left. When sending you the MRI contents, do you need the disc/CD, or do you want photocopy images?"
Yeah, so first of all, John Doe, welcome to our broadcast. We need you to fill out the form, which is online. It's going to ask you for information. And once the form is near completion, you'll have the opportunity to send us your MRI by giving us a portal address and username or credentials, login credentials, so we can access it through a portal. Or you can send us a CD with your MRI images, but we do need the images. We need all of the images, not just a couple. We need all of them. So you could also sweep the images off of a file that you may have on your computer, sweep them onto the website. We can accept those DICOM images. They're all DICOM images. So you have several choices. You have three choices. One, sweep your DICOM images onto the portal, and then we'll put them into our PAC system and be able to view them. Or two, send us a CD with the images on them, as well as your report on the CD, which is actually, it's really the easiest way to do it, as long as you can get a CD from the MRI center and send that to us by mail. And then the final option, as I said, was a portal with login credentials. And remember, portal login credentials usually expire after a certain amount of time, usually 72 hours or so. Okay? But any of those formats is fine. And I look forward to trying to help you out. But listen, a lot of people ask me, can this surgery work for degenerative disc disease? The answer is yes. And the reason is simple. It's not the degenerative disc that's causing the symptoms. It is the annular tear that causes the back pain and leg pain. This patient is exceptional in that his herniations are so big. They're literally like the size of Mount Everest, you know, for herniations. On a scale of 1 to 10, size-wise, they're 10s. And they're literally crushing his nerves. So that's why he's not really a annular tear, you know, back pain kind of patient. He's more of a, I'm paralyzed, my nerves are crushed, I need you to unpinch them. So it's very rare that we ever see patients like this, thank God. Most people get their discs fixed before they get to that stage.
All right, our next question comes from Gaurav on YouTube. Apologies if I pronounced that wrong. And their question is, hello, Dr. Deuk. Love how good you are at your work. How is the Deuk laser disc repair different from the laser endoscopic discectomy that is offered in other clinics?
I get that question a lot. Nobody in the world does the Deuk laser disc repair. And we do an annular debridement, which is what you're seeing done with a laser. Most other clinics that advertise they do a laser discectomy, they don't even use the laser. So they lie to you and tell you they have a laser when they really don't. I've heard of this many times. For example, Laser Spine Institute used to tell people that they Laser Spine Institute, right? But they never use the laser. How do I know this? Because my friends who are surgeons work there. And they told me that the laser was just used in the name. It was a marketing gimmick. So, that said, you see this laser? There is no gimmick here. We use the laser every case, and we use the laser 99% of the time to do the surgery. Show me the videos of the other places, and let's see if they even use a laser, or do they just lie to you and tell you they do. There's a lot of scammers out there, so that would be number one. Number two, Deuk Spine Institute treats the source of the pain. Other laser centers don't. They actually don't know what the source of the pain is. That's why people go get surgery and they still have pain after the surgery, because the doctor didn't properly identify the source of the pain. So you're not just getting the most advanced endoscopic surgery in the world at Deuk Spine, but you're getting the surgery done at the right place. There's so many centers that don't do the right surgery. I have patients all the time coming to us saying that they went and had surgery done on their disc, and they actually had 2 or 3 discs that needed surgery, but they only had 1 done. And they were told by the surgeon that they should come back and get more surgery in the future. Well, why would you want to do more surgery in the future? I don't know any person that wants to have more than 1 spine surgery, do you? I mean, do you know of anybody? Right? So the problem is when everyone's doing the wrong thing for patients, doing multiple surgeries so they can make more money off the patients, then does that make it right to do that? I don't think so. I think it's unethical. So at Deuk Spine Institute, by the way, this is all herniation here. At Deuk Spine Institute, we don't do multiple surgeries intentionally. We do 1 surgery with the goal of fixing the pain and curing the patient. However, sometimes people have obviously more than just a disc causing their pain. And they may have a facet joint causing their pain, in which case we have to do a facet treatment. Or they could have a torn muscle in their buttock called the piriformis, and we have to go and do a piriformis treatment. The point I'm trying to make is simple. You don't come to Deuk Spine Institute just to get the Deuk laser disc repair. You come to Deuk Spine Institute to get the right treatment. Okay? Think about it this way. Let's pretend you are in your house and you walk into your room and you find a baby rattlesnake. Okay? A baby rattlesnake, a baby poisonous snake. And you call up your poisonous snake remover, and they come and they say, okay, we looked at your house and we see you have 5 poisonous snakes. in your house. But we're going to take this one and we'll get rid of it for you, and we'll be back. We'll be back in a few months and we'll do the second one, and then we'll be back in a few months and do the third one. Are you going to want that? Because that's really what your spine surgeon's doing when they say to you, well, we'll fix one disc and then we'll come back and fix another disc in a few months or a few years. Why would anybody want to go through a second surgery? Deuk Spine Institute does the whole surgery, all the discs at one time. So, number one, make the right diagnosis and do all the treatment at one time. That's what we do. Hey, how are we doing on irrigation? And number two, we're really out of irrigation. Come on, you guys got to stay on top of that. Laser off. Let me have the grabber. We're getting close to the end of this disc, and it's been going on for a while because the herniation is just so big.
We have another question.
Yeah, sure.
This comes from Ronald Shepard on YouTube.
Hold the, yeah. Sure.
And they asked, when are you going to have some of the people that had the surgery come back and talk? I can't wait to see follow-ups to hear how everyone is doing in 6 months.
Well, we have those. So first of all, Shepard, thanks for commenting, but we actually have people that come back, and we've had a few testimonials at 6 months. But you got to understand something. We're a doctor's office. We're not a movie production studio for your benefit. I mean, how many doctors have you ever seen that have shown you a patient after 6 months that they treated and they're doing great? Nobody. How many doctors show you testimonials? Very few. If you look at other doctors' testimonials, they may have a couple, like a few, under 5, maybe 10 at most. We have hundreds of testimonials. The reason our patients don't come back in 6 months and do a testimonial is because they're doing so good, there's no reason for them to come back. Okay? Don't you think if there was problems that people would be posting online, I had Deuk laser disc repair and I'm not doing well? I mean, do you realize all these people pay cash for their surgery? They pay out of pocket. Don't you think people who would pay cash for their surgery would be online complaining if they didn't do well? Sure, we have the odd complaint here and there from somebody who had to pay cash, you know, about having to pay cash because their insurance wouldn't cover it. But don't you think that people who are paying thousands of dollars for their surgery would be complaining about it if they didn't get better? If they didn't get really a lot better? Absolutely. So the absence of complaints should be a good indication for you to understand there's a big piece of herniation. And that's because the surgery works and it lasts. And yeah, we're not going to be calling our patients and asking them to come back and do testimonials. These are busy people. They have lives. Their job in life isn't to come and do testimonials for Deuk Spine Institute. So I think it's a bit unreasonable for you to ask for that. But that said, we do have, can you hold that? We do have publications that we've shown the results of our surgery to other neurosurgeons and scientists, and they have published our results. So that's called peer review publication. And peer review publication is really the standard today for proving something works. I'll tell you, we have, for the lumbar, this surgery in particular, we did a study where we looked at any patient that had it done more than 5 years ago, and we looked at their back pain and their leg pain after 5 years. Turns out that we had an average of 6 years for the whole group, 6 years follow-up. and that they had 95% of their back pain was gone at 6 years. 95% of their leg pain gone at 6 years. So show me one other surgery, any other surgery for the back, any procedure in the medical literature that has a 95% elimination of back pain and leg pain at 6 years average follow-up. There is none. That's the best result available in the world. All right, good question, but yeah, we just don't really ask our patients to keep coming back to the office so that we can shoot a video of them 6 months after their surgery.
How about with it?
You know, people go back to the doctor's office because they need medical care. Our patients don't come back because they're doing so well. That should be a good sign. All right, next question.
No further questions, but we do have a comment from S. Dell, commenting from his question from earlier, the junction of the disc and the foramen. He replied, Dr. Deuk, my professor told us that he was doing inside-out technique only. His needle and dilator entry was the same as yours, but the difference was the sheath entry only. Thank you for your explanation.
All right, you're welcome. All right, a lot of herniation here. A lot. Man. All right, let's show the audience the difference between, say, a Deuk laser disc repair and a spinal fusion, which would be the alternative surgery.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
You've seen now how the Deuk laser disc repair is much better than spinal fusion. Spinal fusion is completely unnecessary when you have this technology, endoscopic technology that we have. We are still working on the left L3-4 disc. This is the one that is, let me have a grabber. It's adjacent or next to the fusion, just above it. And what I'm doing is I'm removing the herniation a little bit at a time, and I'm working my way posteriorly towards the back of the disc where the worst bits of the herniation are. And you can actually see how I'm using this surgical instrument called a pituitary to remove bits and pieces of herniation. And every little piece I get out gets a little more pressure off of his nerve. Okay? So our goal here today is really what we call decompression, which means to get the pressure off. Laser. Come on, Oscar, pay attention. Boy, you're going to be remembered as the guy who doesn't pay attention. Is that what you want? Okay. Let's pay attention. I need you here. Mentally, not just physically.
We have a few questions.
Sure, we'll take those questions.
The first one comes from Gaurav on YouTube once more. And they asked, as people grow old and the disc dehydrates, does that reduce the chances for fresh disc herniations?
Yes, great question. So the question was, as the disc dehydrates and degenerates, does that reduce the risk for fresh herniation? Well, it's a great question, and the answer is twofold. You would think with less nucleus that you would get fewer herniations, right? The problem, though, is that the nucleus in a degenerated disc is not normal. It doesn't stay together, clump together. It actually fragments. And then because it's fragmenting, it's easier for it to come out. All right? It's easier for it to herniate. So it's kind of a situation where, yeah, you have less nuclear material. However, you also have less normal nuclear material. And the nuclear material that's there can herniate very easily. So, great question. And the answer is that I don't know. But it would be a great study to look at. You hear that, Arias? Are symptomatic disc herniations more likely in a normal disc, a relatively well-preserved disc, versus one that is degenerated? So you could, look at the outcomes or natural history of symptomatic disc herniation in people with a relatively well-preserved disc height versus those with, say, 50% loss of natural height and degenerative changes. Can you move that, please? Thanks. These are all pieces of herniation I'm trying to remove. And like I said, disc herniations are not one event, they're multiple events. Great question.
We have another question
Yep.
This comes from Ronald Shepard once more on YouTube. And they ask, if out of state, can this be submitted to our insurance, or is this pretty much an out-of-pocket procedure?
Yeah, great question, Mr. Shepard. I don't know what insurance you have, but we handle everybody the same way. That is, we don't have a contract with your insurance, unless we do. And if there's no contract, then they can basically not pay. And they'll worm their way out of paying. So remember, ultimately, payment for medical care is the patient's responsibility. You've got to pay for your medical care. And you hope your insurance will cover it. Now, your insurance may have doctors or hospitals it's contracted with, in which case they have to abide by the contract and pay. However, when a facility like ours doesn't have contracts, then your insurance may not have a contract with our facility. In that case, we cannot do surgery hoping your insurance will pay, hoping and praying. Because one thing we've learned about insurance companies is any opportunity they get to not pay, they'll take it. Now, they leave the doctor holding the bag or the patient holding the bag, right? So what's the number one reason in the world, my friend, for, in the United States, I should say, for bankruptcy? Do you know? Unpaid medical bills, okay? The number one reason Americans claim bankruptcy, and this has been true for 15 years, is unpaid medical bills. So why would you claim bankruptcy? Well, the hospital's trying to get paid, and your insurance didn't pay. So when the insurance doesn't pay, they come to the patient. Well, we can't survive. We're a small company. We can't survive on unpaid medical bills. We can't survive on karma and goodwill. We can't survive on prayers. I'm a big believer in prayer, but we can't survive on prayers. Our overhead every month is massive to cover all of our expenses. And somebody's got to pay that besides Dr. Deuk Majin. You know, last time I checked, the rich people of the world did not make a donation to Duke Spine to take care of the people with bad insurance. But we've been asking them, but it's maybe time patients start asking their insurance companies to pay for medically necessary care and not blame the doctor who did the surgery or the facility that did the surgery. So to answer your question, everybody that has this surgery, unless they have a contract with us, they are going to be paying some amount of money out of pocket. And we will bill the insurance, unless it's Medicare, who will not pay for the surgery, by the way. And in that case, you'll pay some amount up front depending on how extensive your surgery is going to be, right? So easy surgery, less money. More complicated, more timely, more supplies, more staff, more anesthesia, more expensive. That's how it works. And by the way, that's how it works with all hospitals. Hospitals usually will charge for a surgery based on how difficult the surgery is, how much supplies it uses, how much staff it uses. So not all surgeries cost the same. And in spine surgery, definitely not all spine surgeries cost the same. Yeah, we're going to be doing that. Yeah, thank you. That's fine. So, I hope you understand what I'm saying. We cannot survive off people claiming bankruptcy and not paying their bills. And if the insurance company doesn't pay the bill, well, somebody's got to. And that's the patient who's getting the benefit of the surgery. So that's why everybody is going to pay something out of pocket for their surgery unless we have a contract where they don't. And we do have insurances that contract with us to where the patient doesn't have to pay, okay? Man, it is bad. We've cleaned out Probably 90% of the herniation. I'm just trying to get the last bit that's sitting at the roof. Fine. Thanks. I think I've done almost all I can. Let me just look around a little bit. That's where the herniation was. We've gotten rid of, like I said, 90% on this side. And I'm just going to fish around a little bit more. Great questions. So for those of you with out-of-state insurance, yes, we will bill them. We don't know if they're going to pay or not. But you will have to come out of pocket with some money for these surgeries, as does everybody else, unless we have a contract with your insurance.
We have another question.
Sure. You
This
guys see the guide wire from the other side right there? Yep, I'll take it.
This question comes from Gaurav on YouTube once more. And they ask, after the Deuk laser disc repair, what keeps the nuclear material from pushing out of the tear, since the tear hasn't been sealed yet and won't be around for a year?
Yeah, great question. Love it. See the nuclear material down there? It's not coming out, is it? Right now it's not coming out. So what's going to keep it from coming out is the patient following our instructions. Specifically, we tell all of our patients, no bending at the waist. Can we keep that down, please? No bending at the waist for 3 months, and no carrying more than 40 pounds of weight for the first year. So. No, I think we should try to get some of them done. Just let them know that it may be delayed a little bit, but that we're going to do our best to get them done. Grab her.
We have another question.
Yep.
This comes from Sujoy on YouTube.
Hello, Sujoy.
And they ask, Dr. Deuk, can you please show us the exiting and transverse nerve and orient us about the endoscopic anatomy?
I'll do my best. So the traversing nerve is up there at 12 o'clock in that fat, and we don't expect to see it because we're not that medial. The exiting nerve root would be to my left at 9 o'clock. I don't know that we'll see it, but let's take a look. It's going to be in that fat right there. Now there's still a little bit of herniation there. Let's see if I can get that. So the answer is you can't see it in this patient because the amount of fat in the foramen. Hold it. And we're not medial enough to see the traversing root. We have too much fat to see the exiting root. But the exiting root's going to be over there. Let's see if I can get any of this material. If any of it's loose, herniation. Great question. I think I've done all I can on this side. I think I've done all I can on this side. So I'm going to come out of this side and we're going to go to the other side. But basically your traversing root is right there, underneath that fat.
Scope of you want to do this one? Same level?
Sure, yeah.
I mean, that's fine.
Let's irrigate.
Yeah.
So I took out a lot of pieces, but they're all small. But if you add them all up, I think it's substantial. There's a little bit of betadine. We use betadine to clean the wound to minimize the risk of infection. Great questions today. Why is my suction not on? Come on.
Maybe it's full. Check.
I doubt it. Why would it be full? Maybe, yeah, maybe you're right. Because it's sucking from the bag. Yeah, maybe sucking from the bag, that's why. Yeah, because we've been there for a while. All right, so we've put a little antiseptic. We've never had an infection. No, I'm done. With the Deuk laser disc repair.
You want to finish there or you want
I want to finish. What do you mean?
that side or you
I want to do this side.
this one? Okay.
Yeah. And then I'm going to switch sides. Come on in, Jordan. Everything okay? Crystal? Everything good? Watch the needles. Watch the guide wires, I mean. Come on in, Jordan. All right, so we're done with one side of one disc, which took a long time. Far longer than normal because there was so much herniated disc. We're going to work on the L2-3 next. The goal here is to remove as much herniation as we can to create more room for the nerves. If the nerves have more room, then they won't be crushed as much. If they're not crushed, well, then they have a chance of healing. Ah, fuck. You're kidding me. Shot? Shot? Let's get an AP. How the fuck did that come out? My guide wire moved a little bit backwards, so I have to check its positioning. We're gonna have to. Fucking believable. Yeah, should work. Where's the stylet? Oh, okay, I see.
Yeah.
Yeah, I understand.
Watch your finger.
I got it. Shot. Let me have the stylet.
Yes, sir.
So our guide wire pulled back and I'm not happy with its position. So I'm going to have to relocate it by using the needle once again. I could just stick it in there and hope it's in the right place, but that usually doesn't work out too well for the patient. Shot. 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 AP. So when we were messing around doing the endoscopic procedure, we probably caught on the guide wire a little bit, somehow pulled it out, just enough that it came out of the disc. All right, that looks good. Hold on. All right, so we're back in. Just, yeah, go lateral. I knew this case would be hard, but it's hard now for other reasons other than just the size of the patient, the amount of herniation. It's hard for a variety of other reasons, including these guide wires are struggling as well. Okay, let's go ahead and get our dilator down, and we'll start the next disc, which is the L2-3, left side. How is our patient, doctor? Shot? Let's get the mallet. Okay, good. So we're now at the back of the L2-3. We're going to enter this disc. Shot. A lot of people don't like the hammering. He's moving. I need him still. Shot. I think he just coughed, that's all. Go ahead.
Yeah.
All right. Go ahead, get the... What's going on? A little more. Shot? That's good. All right. You shouldn't lose it. It will be close. That's good. Yeah. All right. Let's go. Get at it with the fluoro.
Scope on, please. Thank you.
I need the endoscope.
Endoscope in the setting, please. Thank you.
Oh. That blue is a bit washed out on the TV monitor up there, huh? What is it?
We have a couple more questions.
Yeah, sure.
This next one comes from Andreas Para on YouTube. And they asked, "Hi, Dr. Deuk. In a multiple disc herniation, if one of them is causing the symptom, do you only fix the one causing the symptoms, and why? Not all of them."
Yeah, great question. The answer is you are correct. We only fix symptomatic disc herniations. The reason why is the best we can do with surgery is to make the disc less symptomatic. Okay? So the best we can do with spine surgery is to take away your symptoms. No one's ever going to make your disc look normal. There is no surgery that makes discs look normal. There's no such thing. So all surgeries will make your discs hopefully better, but definitely not normal looking. Now there is argument that, well, if the Deuk laser disc repair allows the tear to seal in the back of the disc, then why not do it and prevent the disc from degenerating further? And that's a very good argument. I agree with you. That is really, in my mind, the only justification for doing this surgery, this particular surgery, and no other, in that you're trying to preserve as much of the natural disc as you can by eliminating the source of degeneration, which is the inflammation happening in the back of the disc, causing the degenerative disc disease. All right, great question. You can see the guide wire from the other side. You can see the tear right there. And we're going to start removing this herniation with the laser. You're welcome to keep asking me questions. I'm happy to answer them.
We have another question. This comes from Will Rivera on YouTube. And Will asks, "Dr. Deuk, hello to you and your team. question, what's your take on microdiscectomy?
All right, Will, great question. What's my take on microdiscectomy? In one word, horrible procedure. Horrible. I would not get a microdiscectomy. Here's why. Number one, microdiscectomies do nothing for your back pain that comes from the disc, because a microdiscectomy doesn't fix the source of back pain. And 100% of people that get surgery on their spine, they have back pain. I mean, maybe there's the odd person once in a while who has no back pain and they just have leg pain. A microdiscectomy is designed to unpinch the nerve root and treat really leg pain, numbness, tingling, and weakness coming from a pinched nerve root. Microdiscectomy is generally limited to one level, not more than one. And the problem with microdiscectomy too is that the surgeon is removing your muscle, your bone, your joint capsule. It's basically a highly destructive surgery that destroys normal parts of your spine just to get down to where the herniation is. I don't believe in doing that. It's unnecessary. This surgery here you're watching destroys none of the spine. The normal spine is left intact with the Deuk laser disc repair. Did you see me remove the lamina? No. Did you see me remove the interspinous ligament? No. Did you see me remove the ligamentum flavum? No. Did you see me remove muscle? No. Did you see me cause massive bleeding? No. So there's no downside to this procedure. There's no damage to your spine, the normal parts of your spine. But with microdiscectomy, there's tremendous damage to the normal part of your spine by the surgeon doing the surgery during the surgery. Okay? So I see microdiscectomy as being a surgery that's going to go away in the future completely. It will become obsolete once patients understand that it's totally unnecessary and it's a really bad surgery. But the consumer has to stop the demand for it. Unfortunately, as of today, the surgeons promote it because, I'll be honest with you, they promote it because it leads to fusion. They want the patient to get a fusion in the future, so they do a microdiscectomy today. And by removing the bones, ligaments, lamina, part of the facet joint, the facet capsule, the ligamentum flavum, by removing those structures during surgery, you're destabilizing the patient's spine. And the patient will be back. They will be back. And they will need more surgery. And that's what these doctors are banking on. Patients needing more procedures. Surgery now on the spine can be done in such a way that you do one surgery and that's it. There's no need for more. Deuk Spine Institute has proven that. If you look at one of my papers I've published, actually any number of my papers I've published, whether it's a fusion surgery or it's the Deuk laser disc repair, the reoperation rate of patients is 1% in the Deuk laser disc repair, this procedure, and it's 2%, I think, in my fusion patients. That paper is on PubMed. You're welcome to look it up. It's called Combined Transforaminal Lumbar Interbody Fusion and Posterolateral Arthrodesis, or fusion, for the treatment of back pain. I think it was published in 2000, I don't know, maybe 16. But you can see that our reoperation rate is only 2% for fusion surgery. Why is that? The reason is simple. I do good surgery. When you do the surgery right, when you do it properly, with good alignment, with good strong purchase, and good stabilization and good reconstruction, then the patients don't need more surgery. Plus, of course, you have to treat all the levels that are symptomatic. So the average number of level treated in my papers is always around 2.5 per patient. And the reason is it's almost always 2.5 discs that are damaged in each patient on average that need treatment. So if you treat the right discs, you're going to get the right results. Most surgeons only treat one disc. That's why patients have to come back for more surgery. I don't believe in doing that to people. I think it's wrong. And I always tell everybody what they need done, and I do it the first time. My father brought me up properly. He said, do the job right the first time, and you will not have to do it again. Of course, that was sweeping and lawn mowing and building things at home, but I applied the same principle to my practice of medicine, and I believe it's the right thing to do for people. Take care of them right the first time, and you won't have to do it again. Now, I think there are definitely patients who have other sources of pain that are not being treated with the laser surgery that we do. For example, piriformis pain, or sacroiliac joint pain, or facet joint pain. Those are common causes of back pain after surgery, and they're not treated with the surgery. So patients still need treatment for those issues, and we're able to provide them those treatments. But they are additional treatments that are unrelated actually to the disc itself. But great questions. Keep them coming. All right, we're just about done with this disc, and I could tell you the amount of herniation I'm seeing here is massive. This guy weighs over 350 pounds, and you know, he has already a fusion at L4-5, L5-S1, so he's lost normal movement in his lower back already from the fusion, which somebody else did, not me. And as a result of that massive weight, plus he's got a physical job, plus he has a fusion, all three of those factors have, I think, contributed to his disease here that we're treating today. Grabber. Great questions you guys have. I love the questions. I'm giving you my best answers. I don't have all the answers, but when I have the answers, I don't mind sharing them with you. We obviously have other spine surgeons watching, which I'm happy that people are learning how to take better care of patients. Keep the questions coming, and we'll keep broadcasting. All right, let's see here. I got to look up here and see what's going on. There's still some herniation there, posteriorly. Dr. Berndes, this is definitely going to be a long one because the size of the patient, the amount of the herniations, you know. I want to try to get through some of this material here. That's the posterior longitudinal ligament just behind the annulus. We're actually in the foramen right now, but I know I had a question earlier. And a lot of surgeons that do endoscopic lumbar surgery will actually start their surgery where we are right now. They'll start in the foramen outside the disc, and they'll look for the herniation and try to remove it this way. I, on the other hand, start inside the disc and work my way backwards. Now I'm going to relocate my tools, and I'm going to try to go more posterior because that's where his herniations are. And I'm literally pushing in my tube, trying to force it towards Luis so I can get a little more posterior and try to get more pressure off the nerves in what's called the lateral recess of the spine.
We don't have any current questions, but we do have a comment from Ronald Shepard on YouTube.
Sure.
He has said, I have had a microdiscectomy at L4 to L5 and wish I had known about this surgery first.
Yeah.
I re-ruptured my disc a year later sneezing and ended up with a fusion.
Yep, very common, my friend. That's what we want to avoid. So one of our viewers just told us about his microdiscectomy experience, and you know, the problem with microdiscectomy, as I've said, it's that the surgeon is taking away to get to the herniation in the lateral recess or foramen. They're literally removing the bones in your spine and the ligaments that hold everything together. So you're going to have a loss of integrity of the normal stabilizing structures of the spine. I don't know, most people may not know it, but the spine is a very important stabilizing structure. It's a column, a very strong column. And, you know, if you don't preserve it, its structural integrity, it's like rusting away at a support beam in a building. That support beam can't do its job if you start removing parts of it. So it's just a matter of time, unfortunately, before the whole building comes down around those beams that you're damaging. And when people get multiple microdiscectomies at multiple levels, well, now they have even more compromise of the spinal stability. So I strongly recommend against microdiscectomy. Now that said, I will tell you some surgeons are pretty good at it, and they can actually get it done with minimal damage to the patient's spine. Minimal. But that said, there's still damage, you know. No matter what, you can't get away from the damage. How's my irrigation? Yeah, well, I would like to not have so much haziness. Fine. All right, let's see what we've got here. Still a little bit of herniation under the exiting roots axilla here. You know, we're so low in the foramen that, you know, the exiting root is up there, and we a lot of times don't see it because it's just buried in fat. I can tell you from experience that, you know, if we're successful here at decompressing his nerve roots, this patient's going to end up having, after surgery, a lot of pain in his legs, because once you crush your nerves so bad from the herniations and stenosis, the nerves take time to heal. And, you know, people have numbness, they have weakness, which takes 6 months to a year to get better and go away. Then they have this burning pain that we call nerve root regeneration pain. And I'm sure this patient's going to have some of those issues after surgery. So let's just hope he can get back some of his strength. Let's take a look at the grabber. Actually, let's go Grabzilla. All right, we're going to introduce you to Grabzilla. Can you see this?
Lights on, please.
We don't use Grabzilla very often. As a matter of fact, you probably haven't seen it used at all.
We see it.
But Grabzilla is a giant grabber. Its job is to reach up and grab pieces of herniation that are hard to get. So I'm going to go in and I'm going to do my best to try to take some more herniation out of this guy. And we call it Grabzilla, come on, because Grabzilla is, it's like it's the Godzilla of grabbers. Let's just go in and look. And we like Godzilla. Anybody not like Godzilla? Dr. Berndes, are you a Godzilla fan? Huh? Let me have the smaller grabber for now. Yeah, me too. When I was a kid, I used to watch Godzilla a lot. More pieces of herniation. Once again, little bits at a time. Nothing overly gratifying about getting these out, but you're basically removing a mountain a little bit at a time. Sometimes it's hard to appreciate progress when you're only removing a little bit at a time, but each of these pieces I take out is another part of the big herniation. And you get enough of them out, you can get great results. So each of these pieces I'm pulling out is its own herniation. So when we talk about herniated discs, we're not talking about one piece of disc that herniated out. We're usually talking about 10 or 15 or 20. If you missed it earlier, we were talking about this patient and how his surgeon that did his fusion in Texas is now in jail because he was taking bribes from the companies that make metal and sell metal for the spine. And I was explaining that that's a very common problem. A lot of the surgeons haven't been caught yet, but the patients are the ones suffering because they're getting all this metal put in that they don't need. The problem is the metal surgeries pay so well for the surgeons. We make a lot of money by doing fusions, a lot more than we do lesser surgeries. So you get some doctors who are just motivated, unfortunately, to do the fusions. I wonder if that's a piece right there I might be able to grab.
We have a question.
Sure.
This comes from Bruce Razor on YouTube.
Hi, Bruce.
And he asked, Doc, I have a question for you. I'm fused from L1 to my sacrum. I'm having a lot of pain from my butt area down my backside. My x-ray shows my SI joint looks okay. Could my pain come from my SI joint?
Yes, yes. So yes, if you've been fused down to your sacrum, there's a very high likelihood your pain is coming from your SI joint. And that's the most likely cause, especially if you look at your butt and you look at the butt crack and your pain is kind of on the side of the butt crack near the top. That's the SI joint, just to the side of the butt crack, about 2 finger breaths to the side of the butt crack, near the top half of the butt crack. That is, as a matter of fact, that is the SI joint, okay? Let's try Grabzilla again. And the way you come on, scope off. We need you guys paying attention. The scope comes out, we get Grabzilla. I need you guys turning off the scope. That was a pretty good one. On what? This disc? 5 minutes. Making some progress. Huh? Yeah. Yeah. No problem. That's quite all right. Scope on.
Scope on, please. Thank you.
All righty. Yep. You need a sacroiliac joint injection. Okay? What is that? Well, if you're worried about your SI joint being the cause of your pain, you get a doctor who can do an injection in that joint. And if that injection takes away your pain, then that means your pain's coming from the SI joint. So you've just diagnosed sacroiliac joint dysfunction. Now, if you want, you can do the free MRI review that we offer. I'm happy to look at you, figure out what's wrong, but I wouldn't be surprised at all if it is your SI joint. That's probably, if I had to bet money, that's where I would put my money, you know, on your SI joint. Man, there's just no end to the amount of disc material that's herniated here. Come on. Well, at least we're seeing the epidural structure starting to drop back in, you know? So I know we're getting pretty good decompression now. That's what we look for. The roof. It's just very tedious, you know? Removing all these pieces just a little piece at a time with such a large herniation. That was a good one. Now, when you start seeing bleeding like this, which is the red stuff, it's actually a very good sign. We're done here. Let me just see if that's a loose piece right there. The bleeding indicates usually a decompression of the nerves. Yep. So it just means that you've gotten the pressure off of the epidural space, which happens to be the nerves as well as blood vessels, right? God damn it. All right, that looks good. Yeah, maybe one more laser and we'll be done. All right, this is a very long and tedious case. So there was just so much herniation. That's a little vein right there, epidural vein. I'm not going to mess around with it. I think I've gotten all I can here. Yep.
Lights on, please. Come on.
Irrigation. Try to clean the shaft before you hand it to me so it doesn't stick. Any more questions?
No current questions, but we have a comment from Bruce, commenting from his last question, and he
That's
says, "Thank you so much."
You're welcome, Bruce. I think you need an SI joint injection, Bruce. I don't know if you're in the Florida area, but if you are, come to Deuk Spine. Let us do your injection and treat you. The good news is SI joint problems typically get better with shots and therapy. Watch those. So you might need 2 or 3 injections of steroids into the joint, but you also need proper physiotherapy to treat that joint. I would recommend a chiropractor. Chiropractors generally know how to manipulate the SI joint to break up the scar tissue that's causing the pain. So. All right, Luis, we're going to switch sides. Okay, we're done with his left. Let's hope that we've done some good. You can see the screws and rods from his prior fusion. Again, we didn't do that fusion. Shot. All right.
Yeah, thank you. No, one is fine. Thank you.
I'm going to advance. Huh? What?
The hole is not that big, but I have another dilado. You want to set it right there?
No. Why? No. What are you worried about? That felt pretty good. Take that. Let me take the guide wire because there is a bend at the end that is maybe problematic. Yeah, we got it out. This cannot use this anymore. That goes in the garbage. Garbage. Sharps container. Shot. That's it there?
Yes, sir.
Oh. Sharps container, okay? Okie dokie, we are starting the L3-4 on the right side, and we're gonna be ready?
Yeah, let me see.
Yep, keep going.
Yeah.
Keep going. Should be good right there. All right. Any questions from our audience?
No current questions.
Okay, great. We're going to get the fluoroscope out. We're going to start the Deuk laser disc repair at this disc. I'm really glad we intubated and put the Foley in because this is a lot longer surgery than I expected it, but we made the right call. Okay, here we are at our next disc. Remember, we've already done this same disc at the other side. So now we're going to take the herniations out from this side. If they come out. Got some big ones down here.
Had good blood pressure the whole case.
I'm sorry?
Had nice blood pressure the whole case.
Wow.
Mean of like around 60 to 70.
This herniation's so big, it literally doesn't even want to come out.
Jordan, can you actually move that better for him? I don't know.
No, I'm okay.
Are you okay?
Yeah.
Okay, so that's okay. Thank you.
I mean, it could be a little better, but oh my gosh, there's so much herniation. And it's just not wanting to come out. It's so big.
Well,
Yeah, that's fine. Any questions for me?
No current questions.
Crystal, she should say hi to his family out there so that everything's going well.
Yeah, let the family know if things are going really well for him, and we'll be done in 30 minutes. Oh my God. Grab Zilla. Wipe it. Scope off.
Please. Thank you. Thank you. Seen a lot of the blue dye in there, huh?
Oh, just pieces of herniation that are massive. And the little grabber just isn't able to pull him out. It doesn't have the force needed, you know?
Got more leverage for that.
Huh?
A little more leverage, too. Pull that force.
Yeah, Grabzilla is special. We don't get to hang with Grabzilla very often.
Nice off. Thank you. I don't think I've ever seen you.
But when we do,
I don't think I've ever seen you use that.
look at that. All that we took out, it still looks almost the same.
We have a question.
Sure.
This comes from Carolyn on Facebook. And they asked, where can I send my recent MRI copies for you? Need surgeon ASAP.
Yeah, Carolyn, nice to meet you. Yes, we will be happy to look at your MRI. We have a process. Thank you. That process involves 3 steps. First, you have to go to the website and click on the free MRI review button. That'll open up a window for you to fill in your information. I have people who are always trying to send me MRIs without doing that. We don't accept it, period. So go to the website, type in, or go to the free MRI review button. Henry will give you that link. And then once you've done that question and answer session, there's the opportunity for you to sweep your DICOM images from one file into our website portal and upload them that way, okay? And that's the way we prefer, because then we have them right away. But you're gonna have to know how to find your DICOM images on your CD or your flash drive. The other option is to send us your CD or flash drive with your MRI images. I'm not talking about your report. We're talking about the actual pictures of on your MRI, which I have to look at. I don't make decisions about surgery based on anyone else's interpretation of the MRI but my own. The reason is other people are wrong 99% of the time. So if I'm going to fix somebody, I need to know what I'm fixing and that it is something there that is fixable. I have to see it with my own eyes.
Thank you very much.
A lot of people think their MRI report is enough for that, but it's not. Definitely not. Okay? And then finally, you're gonna sweep your image PDF file in. Yeah, thanks. So what does that mean? Well, basically, your MRI report should come with your MRI study should come with the report as well as the images. So we want the report and the images. Okay? So just visit the website, deukspine.com, find free MRI review, click on that, and go ahead and fill out the form. And then upload your MRI images or mail in your CD. If you have a portal that you want to use, give us your login credentials and the portal address, okay?
We have another question.
Sure.
This comes from Ronald Shepard on YouTube once more.
Hello again, Ron.
And they asked, what kind of symptoms was this patient experiencing prior to this procedure?
Yeah. Well, this patient's a bit unusual. Our patients typically have back pain, and with or without leg pain. This procedure gets rid of the back pain, it gets rid of the leg pain, as long as it's coming from a herniated disc. Okay? By the way, the herniated disc is the most common cause of back pain. This patient had back pain and leg pain, but he also had weakness in his legs. And the reason is he's let it go too long. And the herniations have gotten worse and worse over time. And they're crushing his nerves now to the point that he can't even move his legs. He literally is paralyzed. I need to grab Zilla. We need to have the scope off. So his surgery is actually an emergency type surgery, in the sense that he's got what we call cauda equina syndrome. Cauda equina syndrome is the most serious condition you can have involving your nerves in your legs. And it's due to pressure on the nerves leaving the spine from the lower back. It is a emergency condition, and it can only be fixed with surgery. Unfortunately, most people don't know that, and they may even go to the emergency room at the hospital. You got it? I got it. And the doctor may not even realize that it's an emergency for them. So they don't get the surgery they need when they need it. It's all about timing, you know? And it's essential that you treat this nerve compression within 24 hours. Unfortunately, this patient didn't get the treatment he needed right away because he's in Texas, and his surgeon was put in jail for criminal activity of taking bribes to put metal in his spine. Basically fusion. So this patient is unique in that they have severe neural compromise from pressure on the nerve roots, from herniated discs in his back. These are the herniations, by the way, right here. This big monster I'm fighting using the laser. Grab her. So, what do you do? Oh, you blocked him. All right, good. You know I'm going to say something about the troll. All right. I've just been informed that not only is there a movie called Troll that you could watch on the movie theaters, but we actually have some trolls here on our chat commenting on inappropriate things, like how beautiful our staff are, which I couldn't agree less. They are, but it's not appropriate. So sorry for the crazies out there that have to post weird stuff. That said, getting back to the surgery this patient's having, it's actually going far better than I thought it would. It's just very tedious. For those of you who've watched me do these surgeries before, this one is taking far longer than any one we've ever done. And it's because of the complexity. He's a big guy, and we're trying to get as much of the pressure off those nerves as we can from his herniations. Now, he would be a risk for reherniation, only because he's so big and the damage to the disc is severe. However, that said, I think he's going to do fine if we can get the pressure off the nerves. I think he's going to do well. I think he's highly motivated to recover and do well. He wants his life back. He's young. He has a beautiful young wife and family, and they're very supportive, and I know he likes to work, and he wants his life back. So he's motivated to do the recovery the way I want him to, which is to take it easy for a year. He's going to have to do some sweeping and maybe do some light jobs, but eventually his disc will heal because we're fixing it with the debridement, and he'll go back to having really good discs that are strong. All right, just a few more minutes at this disc. You can see the epidural veins, the herniation. Now, for those of you who are going to stick around for a few more surgeries, our next patient is actually from Texas as well. And he is flying here to Deuk Spine to have his neck fixed and his back fixed and his thoracic fixed. He actually has cervical pain, neck pain, and he has back pain, and he has leg pain and weakness. He has left arm pain and weakness. He has thoracic facet syndrome. So we're going to be doing 3 surgeries, 3 procedures. We're going to do it all in 2 surgeries. Today is going to be his neck. Next week we're going to do the back and thoracic. And he came here, and I still get a laugh out of this guy because he's, I don't know what he does, but he's some type of a pilot.
Helicopter.
He's a helicopter pilot?
He had to retire because of his back pain.
Oh, okay. So apparently he's a helicopter pilot, retired because of his back pain. That said, he came and said to my staff, he showed up the first day, I think it was earlier this week on Monday. He said, I'm not leaving here until Dr. Deuk fixes me. I thought that was great. So that's what we're going to do. We're going to fix him. I'm actually excited to help him as well. Oh my, this is the never-ending herniation, you know, it's so much. And to make matters worse, we have little flyers that don't want to leave, you know. Starting to get annoying, like this little guy right here. Finally, we got rid of him. Any questions from our audience?
No current questions.
Excellent. All right. Yep. This is all herniation here that I'm debulking. This is fat, just getting in the way, obstructing my view, so I have to deal with it, but otherwise we'd leave it alone. This is kind of following the herniation right here. This is what's putting pressure on the nerves, specifically the traversing nerve root, which is going to be just behind this at 12 o'clock. Remember, I switched sides for this disc, so we're now on the patient's right side. How is he doing, doctor?
Doing well. Vital signs look good. Blood pressure looks good.
Good.
He's doing very well.
All right.
Hopefully.
Let me have the Grabzilla. I'm going to make a grab at it.
Scrub off, please. Thank you. Thank you. Well, you just timed the very last one for me like you do. Try to start making vital extubation.
Yep.
Can't be too aggressive because he's prone.
You take your time. You do what's in the patient's best interest.
Scrub on, please. Thank you. Yeah. Lights off. Thank you.
Sometimes the laser needs a little help. That's where good old Grabzilla comes in. You know what they say? Get by with a little help from my friends.
We got the 18 here.
Hmm?
We got the 18 here, my friends.
This is a lateral herniation within the foramen. Look at all that. Scar tissue. It's definitely a multi-year injury, you know, multiple years, multiple injuries, multiple herniation, just building and building and building on itself.
He said he played football for many years, and that's where he fell.
Football, wow.
He was a lineman in Wimbledon.
I believe it. He's a big man. Lineman?
Yes.
Mm-hmm. Played in Texas?
Yes.
All right. Just about done with this disc. Want to finish this area right here. Almost done. I may want to bring Grabzilla in one more time. That's a picture perfect Grabzilla moment right there. Get grabber ready.
Right.
Grabzilla.
Yes, please. Thank you.
Just not really grabbing much. Not much left, I guess, to grab.
Scrub on, please. Thank you.
Okay. This should be our last brouhaha here, and then move on to the next disc. I still feel like I can get some more of that, though. I don't know why Grabzilla is not getting it. Let's have the other grabber, the smaller grabber. Maybe we need more of a Romeo approach rather than a Brutus. We'll let Romeo sweet talk the herniation. Oh yeah, it's a good piece.
Sometimes
Romeo, Romeo.
gentle is good too.
Sometimes gentle is good. That's nice, actually. It's pulling the roof down. I mean, it's reducing the herniation into back into the disc, which is what we want. Look at that, how much we've gotten. with that sweet little move. Sweet little Romeo. I think this is the longest I've ever spent working on a disc. But I really, really want to help this patient walk again. Grabber? I think we all do. Everybody here is rooting for him.
Super nice gentleman.
Really nice family, and well, doesn't matter if they're nice or not. It's our job to help everybody as much as we can. God damn. All right. Good. He's doing good, wife. He's doing good. I just want to get as much as I can. The more of this stuff I get out, the better his results I think will be. I mean, there becomes a point where we've gotten as much as we can reasonably get out. And then you're just gilding the lily, as I say. But you can see there's not much herniation left. How much fluids have you given him?
3,500.
And he was super dry, right?
Yeah.
But the stats are good?
Yeah, dark amber urine. Very dark.
But he's not retaining or anything, right?
We've had 800 since we started the case.
But you're happy with his fluid balance?
It's the same amount of time, 800. We're going to have to look at the swelling.
Is what?
We'll look at his facial swelling, airway swelling. It should be okay.
Yeah, you know, we do prone fusions for 4 or 5 hours all the time.
If you calculate his maintenance is high.
Just about done with this one. Then we've got one last one to go. Yeah. This should do it. One more attempt here. And then we should be done with this disc, and we'll move on to the last one. You can see the end plate. Part of the problem, by the way, is that the remaining pieces of herniation are scarred down to the bones in the back of the bones, making it very, very hard to get to them. And every time I go back a little further, I readjust my trajectory. I'm able to get a little bit more. And like I said, every little bit counts, so happy to take the time and do it right. Grabber. That's it, Luis. I see the bottom of the nerve up there. See it at 12 o'clock?
Oh, yeah.
Right there?
Yeah.
I wonder if I can get just a little bit more. Oh, and then we'll be done. This is my last pass with the laser. All right, any comments from our viewers?
No current questions, but we do have a comment from Bruce Razor on YouTube and saying this looks like a bad one.
Looks like a what?
A bad one.
Oh, this is, you're right, Bruce. This is like, on a scale of 1 to 10, this is probably an 11, to be honest with you. But I knew it was going to be bad going in, and, you know, I knew that he needed this done, and that he needed really an extensive debridement. Extensive, and that's what we've done. So, feel pretty good about it. I've gotten all I can. I think he's going to see an improvement. There is still this little area over here I want to work a little bit more. See how scarred that is right there? That's all scar tissue from the herniation. Doing all right? Luis?
Yes.
All right, that should be it. I can't get any more. That would be the nerve root right there. We're pretty much done here. We're going to move on to our last disc. Let me just try the grabber one more time. I cannot get anything more. That's it. Let's try the laser one more time. This should be it. Oh. Most spine surgeons would have just stopped by now. Just because they've got a tee time, you know. But I don't play golf. Okay. That's it.
Lights on, please. Thank you. Stop off, please. Thank you.
We got one more to go, folks. This is probably the longest one of my career. 16 years of doing this, huh? Yeah. Normally, we would have done 3 surgeries by now. And can you see here, Henry? Can you see?
Yeah, we can see.
Take a look at this. Look at all the pieces of herniation just sitting on my gloves, right? We've had a lot of them just come out, kind of float out. And that's good. The more we get out, the better for the patient. So out comes our tube. A little pressure on the muscle to keep it from bleeding. We're going to bring the fluoro in and the last disc. So far, I'm really. Oh, I need a Wendy's spicy chicken breast sandwich, plain, on a bagel, on a what do you call it, pretzel. That's my cheat it. That's my reward for the day. I get my Wendy's chicken sandwich. We ought to get sponsorship by Wendy's or, you know, some food company, at least.
What was that place that used to give us the really good food?
Nico's. Yeah, he went out of business. Oh, Greek food. He had the best Greek food. It was the best. But Nico's? Shot? Yeah, Nico, God bless Nico. He's a great guy, but he doesn't know how to run a business, you know? It's just down the road. He used to cater. Shot? No, he's not there anymore. But he used to cater it here, you know, once in a while. And Shot? Yeah, he had a variety of food. I was always getting him to make me burritos. I love burritos, so as my kids and wife could attest. Yeah. I told my wife last night I could eat Mexican food every day. Every day. That's probably the only food I could eat every day. I like gyros too. Did you just say keto ravioli?
Yeah, it's just made with mozzarella cheese. The ravioli is actually the cheese. You bake the cheese.
We need to get an MRI of your brain. You don't ever say keto and ravioli in the same sentence. You're going to make the Italians cringe. Sounds good. All right. Well, if you've stuck it out with us, we've got one more to go. This will be the last disc we're fixing in this patient. It is the L2-3. And there's some blood already there. Why? Because we already did the other side, remember? We did the other side. So because we did the other side, there will be a little bit of bleeding in here when we get in here. Let's have thinking about Grabzilla. I don't know. Let me have Grabzilla. Grabzilla. I don't need the lights on. Just turn the scope off.
Thank you.
Oh, did you hear that sucking noise? That was a piece of herniation. Good.
Thank you.
Oh, still there. Grab her. Another piece. So this This particular disc and this particular side must have had a lot of herniation. All right, any questions from our
Yes.
audience?
Yes, we have a question from Brad Adams on YouTube.
Hi, Brad, welcome.
And they ask, what are symptoms of failed fusion at L4, L5 with no movement in the hardware versus L5 to S1 disc causing pain? I am trying to determine if my failed fusion is causing my back pain or my L5 S1 disc.
Yeah. Well, Brad, you cannot make that determination. First of all, sorry. It requires a really experienced professional like me. But to help you along the way, just based on my experience of doing spine surgery for 26 years and really doing thousands of surgeries, including fusions, not even thousands, 10,000, the most likely cause of your pain is going to be your L5-S1 disc. What's the chance your symptoms are the L5-S1 disc, the adjacent disc, versus a failed fusion? About 98% that it's the disc above or below your fusion. All right, 98%. It's about 2% that it's your fusion. There's lots and lots of failed fusions out there that don't fuse. And as long as your hardware is not loose, then it's very unlikely that your failed fusion is the cause. Okay? So we get this all the time, and I'm extremely confident in my answer. But there is a way to find out for sure, and that is to have Deuk Spine Institute examine you, specifically me. We offer that through the MRI review, or you can come in and see me in person, and I'd be happy to figure it out for you, but it's really not that hard. I'm going to look at your prior fusion. I would want a CAT scan. I'm going to look and see if you have loose hardware. Is the screw loose or not? And if the fusion looks, even though it may not be a solid fusion, if it looks good, if it looks stable, then I would say the chance that that's causing your pain is virtually zero. The most common cause of back pain after a fusion is an untreated disc or adjacent disc. And that's what this patient has, by the way. If you look at his x-rays earlier in the broadcast, you'll see he has a fusion at L4-5 and L5-S1. And that he blew out the disc above. We've got 10 minutes. 10 minutes. He blew out the disc above and below above his fusion, at L3-4 and L2-3. And he was having horrible back pain. And when I talked to him over the internet, we did a MRI review, he was having back pain and leg pain. And he was still walking around, like a normal person. He just had some pain in his legs. Then about a week ago, he blew out even more disc, and now he can't even walk. He's literally paralyzed. So he came to me yesterday from Texas in a wheelchair, and I told him, when you let it go this long, this bad, is small chance you're going to be walking again. Maybe 50-50 in the best case scenario. So he knows. His family knows. God willing, there will be an improvement and he'll back to walking. But my point I'm trying to make to you, my friend, is that it is the adjacent disc until proven otherwise, okay? And I don't know who you're talking to out there, but you need to talk to somebody who knows what they're doing, like me. You're going to switch my irrigation again? Okay, why not?
So about 5 minutes, right?
8 minutes. 8 minutes left. That's a Deuk Mage in 8 minutes, So let's hope it's 8. But if I find something that I'm working on that I need to get, I'm going to be here longer. You know, the longest surgery I ever did in my career was a brain tumor with one of my attendings at Shands Hospital in Gainesville at the VA. And this particular attending, Dr. Roper, I have a special place in my heart for him. He was my mentor when I did my epilepsy surgery research, my epilepsy research. And I got an NIH grant to do research, my own grant, but he was my mentor in it. Anyway, Dr. Roper is literally the slowest surgeon I've ever met in my life, and he knows that. And we're friends now, so I could say it, but the residents hated operating with him because he was so meticulous and careful. He would quite literally take the tumor out one little piece at a time, like a little piece. So we did a 17-hour surgery together and took the tumor out of a patient's brain at the VA. And that was the longest surgery, 17 hours. That was hard. But neurosurgeons, yeah, they're a tough breed. And Dr. Roper, not afraid of work. That's for sure. Great man, great surgeon. So a few hours surgery is not a big deal, basically, is what I'm saying. Not for me, it is. Luis is tough, too. My right-hand man. My whole team. We're ready to do what it takes to get the job done right. Okay. So far, everything's going well. The anesthesia is going well for the patient. He's doing very well. He's stable. No cardiovascular issues. We're waking him up now. We're starting to wake him up. Dr. Berndes has shut off the anesthetic, and I'm going to be done soon. I could see the back of the herniation here. Any questions for us?
No current questions.
The reversal agent now.
We do have a comment from Brad Adams, who commented, "Wow, thank
Yep.
you. I will set up my MRI review soon. I just had one a few weeks ago."
Nice. Well, we look forward to helping you. How long does it take for the reversal agent to actually work? Berndes?
From 7 to 15 minutes. A little different every patient.
Okay. But you can still snow them with propofol if you had to.
Oh, yeah.
Yeah, I'm literally just about done. I mean, really. No lie. See this? This is the back of the herniation right here.
So how do you ventilate them without muscle relaxant? If you drive their CO2 very low.
Because he's going to be weak anyway. Right?
You drive the CO2 low.
Huh?
I have a CO2 lower.
He'll drive himself?
So if you drive the CO2 lower, he won't buck your car.
He won't what?
He won't buck if you drive the CO2.
Oh, okay.
That's how you ventilate patients without muscle relaxant. You were asking the other day.
Yeah, I know it's hard to do though, but all right, 1 minute. Let's see the grab. I feel like I'm playing a game of Tetris here. Damn fat got in my way. Let's see here. Give me a second. Need to get this fat out of here.
So when we extubate, okay, we're still going to be having him sit up.
All right, well, I'm about to be done, and if you have any more questions, I'll take them. I'm going to come talk to you in the conference room shortly. But as far as this patient's surgery goes, we're done. And let me see the grabber. We're just going to do one more exploring of the epidural space over here. Yeah. Type your questions up for me. I'll be happy to answer them. Luis, great job. Everybody in this operating room. Really tough case today, but we got it done. Let's get him recovered and home with his family and hopefully making a recovery. Feel free to type questions up. I'll answer them for you face to face. Vámonos. All right. So let me show you the incision. Can you guys see this right here?
Yes, we do.
That's the incision. I'll show you his incision from his fusion if you want to see it. It's right here. It's literally from here all the way up to there. So what a difference, huh? The endoscopic is far less invasive. As a matter of fact, this surgery doesn't even require opioids, painkillers. All right, I'm going to send some help to you guys, okay? Thank you very much. All right, go ahead and type up your questions, and I'll be over there shortly to answer them.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle